Good morning. Today I'd like to talk to you about a very important topic, and that is lung cancer screening. So lung cancer screening is something that many of you have been asking questions about because the role of lung cancer screening in population health has changed. So we're going to dive into a couple of those topics today, and I hope to address with you the importance and also convey to you how to properly go about lung cancer screening. So first and foremost, the incidence of lung cancer today remains the second leading cause of cancer in both men and women. And although it's the second leading cause of cancer, it's the number one cause of cancer death in both men and women. Now let's talk about a little background on that. If you look across the United States, we in Texas fall about in the mid-range of the incidence of cancer. So this is a very important topic for us to take on with our patients and to know how to implement lung cancer screening in our practices. So that's the background. A little more about background that you should be aware of. How many people are really at risk of continuing to develop cancers is directly related to smoking, which we've known for some time. And if we look at our current cancer rates relative to who's still smoking, for people who are of the age of 18 and above, in the state of Texas, we fall just below the rate, the percentage of smoking that's ongoing in the United States, which is at 17.5%. So although our patients know that there's a direct correlation between smoking and development of lung cancer, we still have a very high incidence of people smoking. So this is a very real problem for us as providers. If we look at lung cancer statistics, we also know that if we discover that a patient has lung cancer and we detect it at a localized state, there's a 54% 5-year survival rate. If it's still regional, meaning not localized, the survival rate drops to 26%. And if it is distant, metastasized, when we discover it, then the survival rate at 5 years is at 4%. So of course, the obvious answer is that we want to discover lung cancer at the earliest possible moment. And the way to do that is to look at screening. So if we talk about our goal, scientists have currently said that they are afraid that we really can't do very much to stop lung cancer. And that's because they think that lots of cancers are a result of gene mutations that occur randomly. And if that's true, what's going to be our goal with the screening program? What's going to be our goal in terms of decreasing the death rate due to cancers? And I would argue that, as was said by Christian Tomasetti, a PhD from Johns Hopkins, the goal, if 2/3 of cancer incidence across tissues is explained by random DNA mutations, then we should focus on detecting cancers early so that we can impact curable rates and death rates. So detection is going to be our key, our mainstay of decreasing these cancer deaths. So how are we going to do that with lung cancer? We can do it through lung cancer screening. Well, until the National Lung Cancer Screening Trial came about in 2011, there really was no way for us to do this. But the skies parted and we were given the NLST results. And the NLST was the National Lung Cancer Screening Trial, which involved a multi-center trial across multiple academic medical centers. It included 53,000 smokers and more. They used 26,000 participants to test low-dose lung cancer screening, and the other half went to chest x-rays. And the results, as you might imagine, were that we did detect earlier with CT, but for the first time, we saw an outcome of a 20% reduction in mortality. That's right, a 20% reduction in mortality. There were some additional findings in the outcomes from the National Lung Cancer Screening Trial. We had a 36% false positive rate, meaning that some of the lesions that we saw on the low-dose CTs were picked up and ended up not being cancer. We also saw a 7.5% incident in incidental findings, meaning we may have seen an abdominal aneurysm, or we may have detected a renal cell cancer, which one would argue might be a good thing. But overwhelmingly, the big point was that we saw a 20% reduction in mortality. This is huge. And again, I'm going to emphasize, this is the first time we were able to make an impact on cancer death rates due to lung cancer, the leading cause of cancer death in Americans. So this key turning point was huge with the NLST. Low dose CT, total number of cases, just to recap, 26,000, with a 20% reduction in cancer death because they went on to early treatment from the early detection. So now let me tell you about our program at UT Southwestern. And this is something that is emulated in other programs across the nation. We have a directorship that is headed by a radiologist. Some programs will have a pulmonologist and a radiologist, or a thoracic surgeon and a radiologist. But the key word here is a program around lung cancer screening. You have to have your patients involved in a program and not just a test. The additional components of a program are going to include that we have thoracic surgeons that are available to see the patient once we have an abnormality that's been detected. So early detection and early management is a key component. Our thoracic oncology group also has a team of providers that are going to look at the best treatment and management strategy for the patient dependent upon the stage in which the cancer has been detected. Our nurse coordinators play a huge role. They're going to explain to the patient what's necessary in terms of follow-up, which we have to remember that screening is not a single event. It's a marathon event to be effective. If you get a negative result one year, it's important that you come back the following year for this to be effective. Your risk for developing lung cancer does not stop with one clean bill of health. If you stop smoking, it takes 15 years before you come down to the average risk for development of a lung cancer. So you have to screen and you have to rescreen. The additional components of our program include our education to our technologists who are performing the lung cancer screening. They are performing this using a very low dose of radiation, and they're trained to do that. So this dose is so low that it's almost approaching a chest X-ray dose. So we use a number called 1.5 millisieverts of dosage for radiation to be our quality benchmark. So this is key to a good program. Now, last but not least, a program is going to include smoking cessation. We don't want to just detect early lung cancer. We also want to change behaviors that put our patients at risk. And that means we need to be able to provide them with a smoking cessation program. And the only thing I'm going to say about that is that this program is frequently offered free in many health systems. And I'm going to have my colleague, Maria Grabowski, follow me, and she's going to talk more about the program. So I'm going to skip over that for now. The additional way that the program works, let's walk through the algorithm. So with scheduling, a primary care physician can write an order for a lung cancer screening exam to be performed, provided that the patient meets criteria. We're going to cover those criteria shortly. A patient can also self-refer to our program. They self-refer by calling in to our provider or to our cancer answer line, and then if they ask questions, they will be directed to a coordinator who will get that patient lined up with the provider that's going to educate them about the screening program. Then the patient will be scheduled. So what are the criteria that qualify a patient for screening? First and foremost, we do not screen patients unless they are of age 55. 55, I want everyone to remember that. Age 55 is the point where we can start doing lung cancer screening. Now, dependent upon the healthcare plan that the patient is under, if they're under Medicare, they cut off screening at age 77. And that's simply because They feel that the longevity or the lifespan of the average individual for longevity's sake, if you get lung cancer after the age of 77, are you likely to die from the lung cancer, or are you likely to die from something else? And so they've cut it off at age 77. But we do have a self-pay policy, and so patients can get this after the age of 77 by paying out of pocket, and we've tried to make those costs as reasonable as possible. But remember, start at age 55 for patients who have no history of cancer, a 30-pack year history of smoking, and have not stopped smoking within the last 15 years. That's key. If you have a patient who's done a great job on smoking cessation and it's been greater than 15 years, their risk have actually reduced back to that of the average person who does not smoke. So again, age 55, still smoking or did not stop within the last 15 years, no symptoms. That's key for screening. You should be asymptomatic. Then those patients qualify for lung cancer screening. This is agreed upon not only by MEDICARE, but also by the American Cancer Society, the American College of Chest Physicians, and many other associations that are looking at the best time for patients to screen for lung cancer. And really, they're falling back on, again, the National Lung Cancer Screening Trial, which is a multi-center trial with evidence-based outcomes. So we know that this works. It works to do what? That's right, reduce mortality by 20%. Now the actual exam is very quick. If you notice the moving picture on the right, you'll see that the time for doing a lung cancer screening is less than the time that it took me to deliver most of this message. That latter still spinning screen, that's our older 16-row detector scanners. And they still, before I could finish discussing this, have finished the complete scan. So the patient's time to do this is nothing. It's infinitesimal. So this is something that I encourage you to encourage your patients that are smoking or have stopped in less than 15 years to think about, to encourage them to screen, because it's not too late. We can prevent cancer by early detection, or we can prevent cancer death, I should say, by early detection. The radiation dose, again, the equivalent of approximately 5 to 10 chest x-rays. If you are on some of the older scanners, some of the newer scanners, it's approaching the equivalency of just getting a simple PA and lateral chest x-ray. Not quite there yet, but it is approaching. So all this to say that they shouldn't be fearful of the amount of radiation exposure. The scan occurs from the lung apex down to the diaphragm, and again, it's a very fast scan, and importantly for your patients who are shy of needles, there's no needle involved. Now, how do we manage the results? Once we get the results, by far, most of our patients are not going to have a lung cancer, and they're not going to have something that we're concerned about being a lung cancer. With those patients will receive a letter in the mail that tells them that you have a clean bill of health. We expect to see you back again next year for your next screening exam. Their primary care physician will also receive a copy of this same result. And we do that whether the patient self-referred to our center or whether the patient was referred. So for a self-referral patient, if they see one of our providers that is going to talk to them about screening, their primary care physician is always listed, and so we also send follow-up to their primary care physician. We want to keep a team approach. We need their primary care physician to be in the know as to what's going on with that patient. The results will also post to MyChart if the patient is in EPIC at UT Southwestern. If they are not, if you're one of our UTS CAP or one of our Southwestern Health Resource affiliates, then we will also send those results to you in the way that you've indicated that you like to receive results. If that's by fax or if that's by eClinicalWorks, those results will be made available. So negative results, we end up with happy patient. Now we will have, as we mentioned before, some false positives and some positive results. If we have a positive result, meaning that we see an opacity that might be a cancer or is concerning, we don't know what it is, it's indeterminate, then we're going to call the patient. We do not send positive results to patients in the mail without attempting to contact them first. So we are going to do that, or if you prefer, if we notice that you have already contacted them, then we leave that conversation to the primary care physician. But be aware that we will reach out to the patient and contact them before sending them a letter in the mail to say that they have an abnormality that we would like them to come back into the center to be seen again. This is very similar to how we run our mammography programs, which most of you are familiar with. So you know that we take care of the entire patient. That is our goal with our lung cancer screening program. Now, should we not be able to reach that patient after 3 attempts, and should we not be able to reach the primary care provider, then we will send a certified letter to the patient asking them to call us. We are not going to give them the results on that letter. We're going to ask them to call us, and then that patient will have an opportunity to have a discussion with one of our physicians or one of our patient educators. That's just a sample of our certified letter that we send out. Now, when we receive a finding that has an abnormality on that finding, thanks to the lung cancer screening trial, we also have a standardized way in where we follow and manage that patient. And again, these are based in evidence, so we know how the outcome should go, meaning that if we have a lesion that's 3 millimeters or 2 millimeters, we know by following those through that research that was done that it makes no sense whatsoever to follow up on those patients. We do the normal, you return to routine screening. We'll see you back next year. It's only when the lesion becomes of a certain size that we have them come back either more frequently, say at 3 months or 6 months, based off the algorithm that you see on the screen, or we tell them that this is very concerning because it's 8 millimeters or more in size, and we might need to do a PET scan or a diagnostic CT, or perhaps they may need to even go directly to biopsy. And we can coordinate that through our program because, again, we have a program that includes thoracic surgeons and our oncology group. So we can facilitate getting that patient in quickly once we've found an abnormality. Now, if you choose, as the primary care provider, you can choose to refer that patient on to the surgeon or to the system of your choice. But I just wanted to make you aware, we do have avenues to fast track that patient in to see the correct consultation. So again, the reports are generated, the negative reports, or you have no issue, those patients get that report, you come back and see us next year. The positive results, they follow the A.C.R. guidelines for lung RADs, and we see those patients back sooner, or they are referred to an expert for additional intervention. Luckily, we have complete coverage of this service. It's a screening exam, and now, thanks to the Affordable Care Act, all things that the USPSTF have designated as a classification B or above, meaning an A or B, are fully covered with no out-of-pocket expense if the patient meets criteria. And what were those again? Age 55, no symptoms, no history of cancer, current cancer, and they're still smoking or they stopped smoking in less than 15 years. So those are fully covered. So the Affordable Care Act, which I just covered, has been in place since January of 2015. So I just want to make sure you're clear on that because you may have heard about the lung cancer screening program before 2015. It's been in existence since the NLST produced their results. So since 2012, we've had our program up and running. But in 2015, we had different rules to start following because of the reimbursement. Now, again, I mentioned that we do have a self-pay plan if the patient should age out of the program that's affordable. Medicare requires certain steps to be taken for the reimbursement to occur. Now let's cover a couple of those topics with Medicare. So to be a Medicare covered service, you have to meet criteria, which we've gone over, 30-pack year history of smoking. And then there are certain order requirements that they also have in place. The patient has to undergo a shared decision-making visit. Now, what is a shared decision-making visit? That is a clinic visit with a licensed independent practitioner. That means a MD, a DO, a nurse practitioner, or a PA that's qualified to perform this shared decision-making visit. And there are components that need to be included in that visit. So we're talking about the very first time that Medicare patient is going to have a lung cancer screening event. They go in for their visit. During that visit, that provider has certain elements that need to be met to qualify, and I'm going to cover that in the next slide. The good news is that for the subsequent visits or screening events, there is no need for a dedicated shared decision-making visit. After the patient has had one visit, every year thereafter for their screening exams, all they need is to see their primary care physician and they can simply order the test. No special discussions need to occur. There are no check boxes to make sure you cover. Just make sure you order the test for the following year. Now let's talk about that initial visit, the shared decision-making visit. What is the checklist that the provider needs to ensure they cover? They need to talk about radiation dose with the patient. Now, as most of you are not radiologists, I'm going to give you the quick and dirty on this. We're talking about screening patients who are age 55 and above. And a patient who is 55 years or above, this amount of radiation from a low-dose screening exam is not going to cause an iatrogenically induced cancer from radiation. So there is no reason to fear this amount of radiation. And that's the discussion that you should have with the patient. The next thing that you should talk about is the risk and benefit of screening, any type of screening. When we screen, as I mentioned, there are going to be some false positives. And in the case of the NLST trial, those false positives were greater than 30%. But they weren't significant. Once we see something, we need to be able to tell patients this spot that we saw in your lungs may or may not be a cancer. We don't know at this point. We just need to follow the management plan, which in some cases is going to be you have another test in 3 months or you have another test in 6 months. If it remains stable, then we might return you back to just the normal screening pool. So that's the key, to have that discussion of the risk and benefits of screening. So the benefit, potential for 20% reduction in mortality if we detect early. The risk is that it might cause a little anxiety if we tell you that we found a positive finding and it turns out to be nothing. So that is the risk of screening. Now, we have to also talk to the patient about the fact that screening is a marathon event, meaning that it's not a single event. You're going to have to come back every year and do your screening for it to be effective. So that discussion should be made with that patient. And then last but not least, there needs to be a discussion of smoking cessation. Again, we don't want to do this in a vacuum. We don't want to just say, you're good, you're clean this time, go ahead, go back to smoking. No, we want to offer some behavior modification. We want the patient to stop smoking. So CMS wants us to have that discussion. And then all of these elements should be documented in your dictation or in your note from that visit. So those are the components that comprise the shared decision-making visit. Make sure the patient meets criteria and make sure you go through this checklist of items. Now, our private payers, those are requirements for CMS that I've just talked about. Our private payers will usually follow what CMS has put into place. They have not yet done so, but they probably will get around to that. So as it stands, your Blue Cross Blue Shield, your Aetna, your United Healthcare, they all cover lung cancer screening. Again, because the USPSTF gave it a Category B recommendation, meaning that it should be a covered service. As such, the Affordable Care Act requires no out-of-pocket expense for anything that meets a classification A or B by the USPSTF, the United States Preventive Services Task Force. So it's a covered service by your private payers, and they have no requirement for the shared decision-making visit. But it is a good idea. It's a good idea because it's good practice, but also because these private payers are probably at some point going to follow these same requirements that Medicare has put into place. So Medicare patients must have shared decision-making visit for the first visit. Private payers don't require it, but it's a good idea. So just get in the habit of doing that checklist, and those patients will have no expense for this exam. So the goal again, what is our goal in order to decrease the cancer death rates from lung cancer? It is to detect the cancer early so that we reach it at a point where it is curable. So CT lung cancer screening, is it appropriate or is it not appropriate? I say categorically, yes, it is most definitely appropriate and is something that we as providers should pay attention to for our patients. Given again, we know the statistics. Lung cancer is the #1 cause of cancer death in Americans. So we can do something for the first time to decrease those cancer rates. And all we need to do is have these conversations with our patients and get them into a dedicated lung cancer screening program. Thank you.